Hi, everyone. Welcome to our grand rounds for today, April 29th. Thanks so much for joining us. I have the pleasure of introducing our speaker today. This is Dr. Elizabeth Phelan. She is a professor of gerontology and geriatric medicine with our School of Medicine, as well as an adjunct professor of health systems and population health with the School of Public Health. She's also an affiliate investigator at the Kaiser Permanente Washington Health Research Institute. She directs the Northwest Geriatrics Workforce Enhancement Center and is the founding director of the UW Medicine Falls Prevention Clinic. She received her medical degree at Tufts University and then a master's in health services from the University of Washington. Then went on to complete her residency training and was a chief resident at the University of North Carolina at Chapel Hill. She then completed her clinical research fellowship training with the Robert Wood Johnson Clinical Scholars Program in 1998, and then got a fellowship in geriatric medicine at the University of Washington as well. She's been on faculty with us here since 2000. Her research aims to promote health and prevent functional decline in community dwelling older adults through improving quality of care for geriatric syndromes such as falls and dementia. And she will be speaking with us today about age-friendly healthcare. So without further ado, I'll turn it over to Dr. Phelan.
Thank you, Dr. Tan, for that very kind introduction. In August 2017, an 86-year-old male with coronary artery disease, hypertension, and hyperlipidemia presented to his local emergency department with acute hemoptysis. He underwent an extensive workup that was unrevealing except for a cardiac echo that showed progression of previously mild to moderate mitral regurgitation to severe MR. His cardiologist recommended that he undergo a transcatheter mitral valve repair. GR, initials GR, our patient declined. Thereafter, he lost his appetite, began losing weight, and developed progressive dyspnea on exertion and then dyspnea at rest. When he was reevaluated 6 months later, he was told that he was no longer a candidate for the MitraClip procedure. This was fine with him and consistent with his wishes for no further medical interventions, no ER visits, no hospitalizations, just being able to spend the rest of his days at home in the comforts of his own home with his wife. His wishes were met. He died at home 9 months later. I'm presenting this case to illustrate a couple of key points and to set some context for the concept that I'll be sharing a lot with you about today, the concept of age-friendly care. First, that older adults are often very clear about what their wishes for their health care are. And second, that the nature of those wishes may come as a surprise to both the family members and the providers of those patients. So let's keep this case in mind as we dive into this concept of age-friendly healthcare. I'm going to talk with you today about what it is, why it's important, and how we can achieve it. I have no disclosures. For some context, let's look at the demographics of the aging population. The aging population in the US and around the world is growing rapidly. Currently in the United States, there are about 50 million adults aged 65 and older. That number is projected to double to nearly 100 million by 2060. And by 2030, 1 in 5 adults will be age 65 plus in the United States. As this slide shows, for the first time in US history, older adults will outnumber children by 2035. These really extraordinary demographic shifts have left our health system behind in trying to reliably provide care that's evidence-based to every older adult at every healthcare interaction. Take a look at these recent statistics. They tell this story, that is that healthcare for older adults really needs to improve. For example, over 30% of older adults are prescribed a potentially inappropriate medicine yearly. These are medicines that contribute to things like cognitive impairment and falls. Fall-related injuries result in nearly 3 million ER visits by older adults annually and nearly 1 million hospitalizations annually, even though falls are a largely preventable problem. And for those with dementia, only about half will ever receive a diagnosis, meaning that they will have missed opportunities for care planning and achieving their goals for the rest of their life. And these events are occurring despite the fact that older adults have a lot of contact days with the healthcare system. So it's not the amount of care that they're receiving, but it's really the content of the care that needs to change. For older adults from different racial and ethnic backgrounds, and for LGBTQ adults, care is even worse. Data suggests that race and ethnicity contribute to disparities in the quality and extent of services received. As an example, relevant to the mentation realm, memory and mood, in a recent study, patients that were identifying as Black and those with lower SES had less evidence, less documentation of cognitive testing. This suggests that medical care delivered to these groups is different. And this is despite the fact that they have higher rates and risk of mild cognitive impairment and dementia compared to those identifying as whites. Coupled with the demographic pressures on our already challenged health system is the harsh reality that there are very few geriatrics trained providers, certainly too few to provide all the care to all older adults in this country that is needed. And unlike the demographics of the older adult population, the numbers of geriatrics trained specialists is not growing. So what are the implications? Really, the implications are that all providers, regardless of their training and specialty, need to learn and adopt age-friendly principles and strategies of care. Not the least of which is the challenge of the fragmentation of our healthcare system for older adults who often have to cross settings of care, hospital, clinic, skilled rehab centers, and then back home into the community, navigating that system where there is little communication, and if there is, the quality of that communication is often poor or insufficient, is leaving older adults very frustrated, confused, and unhappy. So they really, to address this conundrum, combining all these factors, the demographic imperative, the fragmentation, the healthcare system that's struggling to keep up, what are we going to do about this? What is the answer? So this concept of age-friendly care may actually just help with this situation. So what is age-friendly care? In essence, this is healthcare that focuses on what research shows are the most important issues to pay attention to as people get older. Age-friendly care is evidence-based care that aligns with a patient's core values, improves health outcomes, and prevents avoidable harm. Operationalized, age-friendly care involves routinely applying a framework shown on this slide. This framework is referred to as the 4Ms. It's a set of evidence-based practices within 4 core domains that I'll run through. First, and at the top, and for a reason, it's the overarching M, is what matters. This refers to knowing and aligning care with the older adult specific health outcome goals and care preferences. This is concluding but not limited to end-of-life care. It's the here and now. And this should carry through all settings of care that the older adult moves through. The M of medications is using age-friendly medications, dose adjusting medications if they are necessary, and deprescribing them if they are not necessary. The M of mentation, mood and memory, means preventing, identifying, and treating depression, dementia, and delirium. And lastly, the M of mobility means ensuring that older adults move safely every day in order to maintain their functional ability and do what matters to them. So this is, in essence, a simple mental model that can help guide care decisions, improve decision-making, and address the key factors underlying older adult health. And if we apply it consistently, it will allow us to deliver high-quality, age-friendly care. So in essence, another way to think about the definition of age-friendly care is care that's guided by these 4Ms. When we want to apply the 4Ms, there's 2 steps involved. So the first step is to actually do an assessment within each of these 4 core domains. And then with that information gleaned, trying to incorporate or act on that information and centralize the key findings into hopefully a record that everybody can share and refer to provide 4Ms care on a regular, consistent basis. So for example, it's not just enough to screen an older adult's mobility and their fall risk. You have to have a plan for what you're going to do with that information. These are some other key points around the 4Ms. They're meant to be a framework. So they are meant to be implemented together as a set, a package. Second, they can be implemented by an entire healthcare system or by individual providers or in select practice sites. Third, they should be incorporated into existing care. So they're not an addition. They're just a central key component and sort of centralizing, if you will, strategy for maybe reorganizing care so that it helps accomplish the goals of the patient and meets those other M's as well. And lastly, the tools that are used to implement the 4Ms don't have to be the same in every location. They're specifically not prescribed. They should be evidence-based and they should fit in your particular setting. As an example, so for mobility assessments are numerous, as shown in this slide. So in every setting, each setting may make its own choice of what's going to work in its setting to allow for screening, and just whichever one will be the most feasible to do is the right one for your setting. So let's talk a little bit now about why we should engage in age-friendly care in the first place. First, we want to better serve our older adults, their families, and their care partners. We want to improve on that current state of what older adults are receiving for care. Older adults are heterogeneous and complex. This means that providing care to them is quite challenging. And so any tools that we can bring to bear on that care that can help us do that better is really important. But second, and in early work with some health systems that I'll show you in a few minutes, we know that age-friendly care, when delivered, does promote value. I'll give you a couple of examples. One system reduced its 30-day readmission rates from 20% to 8%. Another reduced the direct care cost per patient on its older adult trauma service by $3,100. And another reduced hospital length of stay by over a day. So you might be wondering, where did these concepts come from? This concept of age-friendly care, the 4Ms framework, and age-friendly health systems. So they emerged from a collaboration of the John A. Hartford Foundation, an organization that has long been in the business of testing care models for delivery of care to older adults through funding, through grant making, in partnership with the Institute for Healthcare Improvement, IHI, leading experts in healthcare redesign for the older adult population, and stakeholders and leaders of several other organizations shown here on this slide: the American Hospital Association, the Catholic Health Association of the United States, and also the Joint Commission. These groups all recognize that a systems approach would be necessary to improve care of older adults. Why is this? Well, this is because this group recognized this too, that we have lots of evidence-based geriatric care models that have been tested and found to be very effective in improving health outcomes, reducing costs, and etc. However, many of these will reach only a small subgroup of the entire older adult population. So few people are actually benefiting in real time from all this research and effort spent on testing these evidence-based care models. And there are multiple reasons why these models have not been scaled or widely translated. And what's actually happening is, over time, the evidence is piling up on what works, but it's not getting translated into everyday care. And in fact, this divide, or this gap, as you can see here, is close to becoming a chasm. So this collaboration of the teams, members of the teams from the organizations that I showed you, delved into the evidence-based care models that have been published on, with high-level evidence identified initially 90 core features of those models. When they distilled them down, removed duplicates, there were 13 care features that remained common across those models. And through expert consensus process, from 13, those final four, the 4Ms, enough that most people can keep in their brain, the 4Ms were identified. So armed with this newly developed framework, in 2017, the team then launched a campaign called the Age-Friendly Health Systems Initiative, with the aim as shown here. And the key premise of the initiative at the health system level was that becoming an age-friendly health system entailed reliably providing the 4Ms to all older adults in the system. This campaign initially focused on the acute care setting, and then in 2019, it was adapted for outpatient settings. Also in 2019, the Health Resources and Services Administration, or HRSA, through its Geriatrics Workforce Enhancement Program, or GWEP, adopted, and I quote, transforming clinical training environments into integrated geriatrics and primary care systems to become age-friendly health systems as a primary objective. So in other words, marrying what we know works in care of older adults into routine primary care practice. Our GWEP, the Northwest Geriatrics Workforce Enhancement Center here at the University of Washington, is engaging with our primary care partners, as are other GWEPs around the country, to help the practices in those and the providers in those practices become age-friendly. And so far, over 2,900 health systems, hospitals, and outpatient practices have achieved this. And locally, just to name a couple that have been early recognized as age-friendly level 1 designation, the VA Puget Sound Healthcare System's Jerry Patt Clinic and the Harborview Senior Care Clinic. Health systems can seek recognition of being age-friendly at 2 levels. The first level is that they're on the journey to become age-friendly. They've committed to it. And they do this by submitting a worksheet to the Institute for Healthcare Improvement that describes how they're working towards putting the 4Ms into practice. At level 2, this designation refers to they're actually accomplishing age-friendly care. They're delivering that kind of care. They're committed to it. What this requires is the site submitting to IHI 3 months of data on the older adults in their practice, describing the number of older adults who have received 4Ms care. Here I'm showing 5 health systems that were early adopters of this age-friendly approach to care. They have all seen results, and some of those value results that I showed you a few minutes ago derived from these health systems. They've all seen return on investment. This is an example from the Providence Health System. Providence developed a bundle for the 4Ms. And looking at the VA environment, currently there are 50 VA medical centers across the country that have been recognized as age-friendly participants. 26 of these 50 have achieved that second level of recognition, the Committed to Care Excellence recognition. Part of the mission of, as I mentioned, the GWEPs, the Geriatric Workforce Enhancement Centers around the country, there are about 50 of them, is to assist practices that are interested in signing on to the Age-Friendly Initiative to meet that challenge. And we suspect that providers will be more satisfied with caring for older adults if they learn how to approach care through the 4Ms. And this will also be time-saving because they'll have greater familiarity with what's really important to focus on. So they'll be able to accomplish that care in less time. I'm going to take a few minutes now to talk about that What Matters M at the top, because as I mentioned in the beginning, it's the framing for the other M's and can really help guide what the care plans for each of those 4Ms looks like. So it's really proving to be a powerful starting point. And again, what this involves is asking patients what's important to them in terms of their health goals and preferences. This goal concordant, or what is now being referred to as patient priorities care, results in optimized patient satisfaction and quality of life. It may also reduce costs of care, If we think back to that case of GR from the beginning, you saw that costs were probably much lower for him because he was not undergoing an expensive medical procedure that would have been against his wishes. He did not consume ER resources and was never hospitalized. And so it's in a sense a win-win when we can achieve a patient's goals and contain costs of care. So one thing to emphasize again about this What Matters is this is not just about end-of-life care. This is about how the person wants to spend their days. So it's what really brings meaning to the person's life in the here and now. For example, being able to have the mobility to walk your dog every day, or to go to get fresh fruits and veggies at Pike Place Market, taking that very steep cobblestone sidewalk to get there, being able to get down on the floor and play with your grandchildren. These are all examples of things that we often hear older adults tell us matters to them in their daily life. There's a recently developed resource called Patient Priorities Care that I'm showing you a snapshot of here. And this resource is to try to help people in practice interact with older adults, their families, their care partners, and are having a conversation or conversations to identify the patient's health priorities. As this, a key tenet of this patient priorities care shown here is that patients are really the experts in what they want to achieve. We just need to help them understand that we care about this and that we can help them get there. So applying the goal concordant care or patient priorities process can help move decision-making from, as shown on the left-hand side, you need this treatment for this disease, to an approach that looks like on the right side of the screen, knowing your health conditions, your overall health, and what matters most to you, I suggest we try. And a recent publication by the team who has worked to develop this approach, patient priorities care approach, has demonstrated that it is effective in reducing unwanted care and also reduces treatment burden. So I'm now going to give you some examples of how this could actually be implemented in our daily practice. So since we've all been experiencing COVID, here's an example of a telemedicine visit that's shaped by this age-friendly or 4Ms construct. First, what matters? I'm calling to check in with you. We know this can be stressful. Right now, limiting our ability to go out, just interacting with others is stressful. How are you doing? What is most important to you at this time? Then let's review your medications. Let's look at each of your pills. Show me your pill bottles. Around mentation, mood, memory, this can be a stressful time. Really, stress can affect our memory. It can make our short-term memory much worse. How are you doing with that? In mobility, how are you getting around? Are you still getting out for your walks? And a couple of case examples to show how care is transformed by applying the 4Ms. First is a case of AM, an 82-year-old female. She was recently hospitalized for a vertebral compression fracture, and she presented for primary care 2 or 3 months later with a new provider. She had never had a discussion of her osteoporosis diagnosis, and she was, by report, feeling quite dizzy and experiencing falls still. And it turned out that she was taking Benadryl for difficulty sleeping at night. The thing that really bothered her the most and was most important to her was the dizziness and not having to experience that dizziness any longer. On exam, she was diagnosed with orthostatic hypotension, which had not been previously discovered. And she was willing to stop the Benadryl and try other options for sleep. She started exercising, walking regularly, and she was also begun an osteoporosis treatment and referred to PT for fall prevention exercise training to help her avoid falls, which were also a problem for her. And then the case of FW, a 76-year-old woman with very few actually chronic medical conditions, just hypertension. She did have a history of some falls, and she had been experiencing a number of near misses and minor fender benders while driving that were really stressing her daughter out. Her daughter was also stressed because she was finding she needed to call her mother on a regular basis after she noticed that her mother had missed some doses of her antihypertensive. So given that situation, in consultation with a provider in the geriatrics clinic, the clue of perhaps there being a cognitive issue due to missed doses of medication led the provider to perform a cognitive assessment, and the patient was ultimately diagnosed with dementia. To address the issue of her driving, an alternative plan for transportation was developed with her family. And the daughter's caregiver stress was addressed through arranging periodic respite for FW and recommending a support group for the daughter. So I hope I piqued your interest in the Agefriendly initiative. In the last few minutes, I'm going to share some resources. I want to show you that there's quite a number of resources that have been developed actually to help practices, providers, and systems who are interested in signing on to this age-friendly journey to do so. So there are written guides, comprehensive guides shown here from the IHI. There are ROI calculators, issue briefs, and case studies. There's a newly produced online course that's free, and it essentially will be available in asynchronous online for whenever somebody wants to go through it. There's also CE training for it, CE credits rather, if you complete it, and action communities that have been run by the Institute for Healthcare Improvement. These involve 90-minute interactive webinars occurring once monthly over a 7-month period, where content learning about the 4 M's is conveyed. There's an opportunity to share with other teams that are participating in the action community. And between sessions, people participating in trying to make age-friendly changes go ahead and test specific changes in their own setting, and then return back to the meetings, the webinars, and discuss challenges, successes, lessons learned. And they share data, and there are optional coaching sessions, as well as a leadership track for those systems that are interested in scaling up their age-friendly efforts. So I want to leave time for questions. So in summary, I've shown you a little bit about what is age-friendly care, the 4 M's framework to help us deliver age-friendly care, this Age-Friendly Health Systems Initiative and its reach, the benefits to date. However, many health systems have yet to embrace age-friendly care. So I'll end with a question for us to ponder, and that question is is UW Medicine ready to embrace age-friendly care? If it is, the Northwest Geriatrics Workforce Enhancement Center would be happy to help. So thank you very much for your attention. It's my pleasure to have this opportunity to share this information with you today. There's a QR code there for evaluating the presentation. If you'd like to complete that, I'd be grateful. And I really look forward to taking your questions and or hearing from you. My email is shown here.
Thank you so much, Dr. Phelan. Feel free to chat any questions that come up. Actually, one thing did just come up. In caring for my mother, I've observed that neither the provider or the nursing home had any interests professionally or economically in addressing these issues. How do we change this?
Yeah, so you point out a really a key issue, which is that the patterns of care delivery that we're stuck in are very time consuming, demanding, and aren't necessarily the right strategy, the right design. And so as the Age-Friendly Health Systems Initiative suggests, it has to be something that the site of care is willing to throw out what it thinks is the right thing and try something new. And that's certainly not easy to accomplish. And the resources around, recognizing the value, if there has to be certainly high level leadership buy-in to recognize that and endorse that if the whole system is going to change. But those are just some thoughts about how to think about that.
One more question is that we work on teams, in primary care clinics. How do you see interdisciplinary care fitting into age-friendly care?
So that's a great question. So the idea is this should be embedded into teams so that assessments, for example, could be done by a member of the healthcare team or delivered by practice support personnel at the population level of the clinic. So for an example, an assessment for fall risk could be done as, what we see and what we do every day. And for example, in our falls clinic here is our medical assistants actually do our gait assessments, our mobility assessments, and gather the information, and the provider then sees that information and can act on it. There's a role for nursing in doing a lot of the assessments as well, but it's something that a whole team can have a role in. For example, a pharmacist around the M of medications. Pharmacists, if they're given the opportunity, could even, and this morning our division heard a presentation about this actually, where pharmacists are initiating conversations about what matters most to patients, and having that conversation then lead to a discussion of what medications might make sense for you or what might not make sense for you given what's important to you.
Thanks. And one more question in the chat. Why hasn't UW Medicine adopted this?
Awareness, potentially. Even so, having worked in the field of geriatric medicine for myself for over 20 years, this is a relatively recent development and reconfiguration, if you will, of how even those of us in geriatrics teach about and think about care of older adults. So it's I would say, number one, probably because it's relatively recent phenomenon. Number two, because everybody's busy in their own daily focused areas of practice, and this is perhaps maybe a bit more overarching. And if you're not in the trenches of care of older adults, it could easily be missed. And so, in thinking about what to present at our grand rounds this year, when I was invited, I thought this would be a good opportunity to try to raise that awareness.
Another question, first with a compliment, great talk. Are there tools that patients or families can share with clinicians who are reluctant to embrace age-friendly care?
Can you repeat that? Are there tools
that patients or families can share with clinicians who are reluctant to embrace age-friendly care?
Yeah, and I think this builds on, that's a great question. I think this really builds on the first question, to the point that sometimes the more can be accomplished and change may be more likely to occur if it comes from that more grassroots or stakeholder level. So when patients actually and families actually demand change or organize to make change happen, that may be a more significant driver and motivator than any other. To that specific question about tools, so the patient priorities care has materials for patients to work through to help them think about and document their wishes, and they can share those with their healthcare provider, their healthcare providers, and take that initiative. Families, as we know, family members are often proactive on behalf of their family members who are aging, and so that could be something that is a care partner could work on with an older adult. For example, if that older adult has cognitive impairment or doesn't have the motivation but would do it if somebody were doing it with him or her. So I think I included the links, and I don't know, Dr. Tan, if the slides will be available, but I did have a link to the patient materials on the slide that showed the patient priorities care image. And there's a counterpart section for providers as well to help guide those conversations.
Is it the My Health Priorities website?
Yeah.
Okay, great. I think that was, I'll just put that in the chat here. And we have another question. Thank you for a very timely and important talk. As primary caretaker of my 80-year-old mom, I see home health services such as PT as a very important component of care in prevention of falls and improving mobility, to name just two key benefits. But it's very difficult to receive that kind of service. What can be done to improve that?
That's $1 million question. We encounter that all the time. The concept of prehabilitation, which again was tested many years ago now by someone in geriatrics, Tom Gill from Yale, where to prevent functional decline and falls and frailty, a prehabilitation approach or intervention was tested that has never gained traction. And certainly, I believe in prevention. I think we just have to convince, CMS and others who fund health, other insurers of care, that this probably makes more sense than paying for the after effects of not doing anything, i.e. all the fall related injuries, the hospitalizations and the costs that those injuries, the treatment of those injuries incurs. It's put it this way, it's not lost on most people who are in the field of either community-based care of older adults or in clinical practice, and it has come up in conversations in multiple national meetings. It is certainly something that we have not been able to change, despite a lot of conversations about that piece. At least at the policy, at the policy level, that I think what you're referring to is that so only certain subset of older adults, i.e. those who qualify as homebound, are eligible for those in-home home health services.
All right. Thank you so much, Dr. Phelan. No other questions have popped up in the chat yet. So if there are any last questions, please go ahead and put those here. Thank you so much for joining us as our speaker today for Grand Rounds, Dr. Phelan.
Thank you for having me. Thanks again, everybody, for being here.
Happy to just leave up this QR code for a little bit longer if you want, just in case people are able to fill out an evaluation. And thanks to everyone for joining us today.